Everyone, I'm Matt Race from Race Dental. Welcome back to the Race Academy live webinar series where we talk today about guided surgery, core principles and technology. So welcome ladies and gentlemen, boys and girls, dentists and others from around the world. Whilst we wait for everyone to jump on board, the last few people now, as usual, I'd like to start by talking through who's joined us today. We've got dentists and others from Australia, Singapore, welcome everyone from Singapore. New Zealand, welcome to our dentists and others from Singapore. Malaysia, it's always nice to have people from Malaysia. We have Japan, hello everyone from Japan. Canada, hi Canadians, and the United States of America. So welcome one and welcome all. We look forward to taking you through guided surgery, core principles and technology today. But before I do, I'd like to throw over to our customer support team. Melissa, are you there?
Yes, welcome everyone. Karen Whitney and I are your dedicated relationship managers. Overall, we have more than 25 years of experience in the dental industry, so we understand the everyday needs of a practice and are here to support you in your partnership with Race Dental. If you would like to contact us, please click on our website, www.racedental.com.au. Thank you. Over to you, Matt.
Thanks, Mel, and it's always great to have you guys in support of what the lab and our supportive team are achieving. It's always nice to have you guys behind us. So, all right, let's get started. We've got about half an hour for all of you people enjoying your lunch. Sit back, relax, and we'll take you through latest techniques and principles with materials for implant placement guides. The first thing you need to know is if you fail to plan, then you plan to fail. And there's no doubt about this, that today's most savvy technicians and most savvy surgeons are definitely planning to the detail for better results, better long-term stability, better patient outcomes, and ideally better patient care. So implant placement guides or implant surgeons guides are defined surgical templates allowing surgeons to place implants perfectly and predictably for long-term stable outcomes. But let's go back to see where we got to how we are today. Traditionally, we used to make these surgeons guides, tooth-borne, clear acrylic stents, and we'd put a little hole to let the surgeon know where we want the access channel for the screw-retained restoration to come out. We then moved across to the third picture. We started placing gutta-percha or GP points through the guides, and these would go all the way down to the ridge and allow the surgeon or the surgeon to see exactly where the soft tissue finished, so the depth of the implant could be placed. And on the right hand side, we soon learned that barium sulfate was an excellent material that showed up in x-rays and radiographs that soon showed where the soft tissue was in respect to the bone, so we know how deep we could place our implants. And these were the first steps we started using to help guide our surgeons in getting more predictable outcomes. Then in 2005, Noble Biocare launched their Noble Guide, where we started putting gutta-percha or GP points across the buccal and labial flanges and palatal or lingual flanges in the patient's denture. So in the x-ray or the radiograph, these points would show up and guide us as to where we need to place those implants. A lot of early failures with this system, unfortunately, created some of the issues, but we've moved along. I think since the launch of Noble Clinician, they're starting to clean a lot of that up. We started putting barium teeth into clear acrylic dentures or making the whole denture out of barium sulfate to try and get our radiographic information in more detail. But today we get the patient's denture, and you see on the right hand side, we put these nipple stickers across the buccal surfaces and the palatal surfaces that act similar to the barium sulfate. We no longer have to damage the patient's denture with gutta-percha to get a similar result. So if you don't know where you're going, you'll end up someplace else. And I think this is a very, very strong, Yogi Berra was actually a baseball coach and player, and he soon learned that if you don't know where you're going, you'll end up somewhere else. And I really love that saying. What do we need to be able to digitize our virtual implant placement? All we really need is a good digital impression. Here's two of the leading ones on the market today, or any STL source from any of the leading intraoral scanners. Couple that with a cone beam computed tomography scan or a CBCT scan. Send those both to the software and you upload your CBCT on the left and your intraoral scan. Alternatively, you can also send us a traditional impression. We will scan that and turn it into an STL file. It'll both be uploaded into the Implant Placement Guide or Virtual Implant Placement Guide software. We position our teeth where the most beneficial position for function, anesthetics, and also hygiene, and then we go ahead and position our implants where they'll be best suited. Here you'll see in the background the CBCT scan of the patient's bone merged with the STL file of the digital impression. The teeth are then positioned where they best function. The holes are then decided where they'd be best. We double check, we align the merge between the CBCT scan and the .stl file scan. And you'll see a nice merge here of the orange line around the two files. And on the right hand side, you'll see from the 4-3 forwards, we have a little bit of an issue with the marry of the two scans, but in the working area here, we've got a lovely result. So always double check the merge of the two files, both ICOM and point STL are accurate, and you will ensure that your placement planning runs smoothly. We then have a look at the CBCT, and you can see our implants positioned here around or in favourable position away from the trigeminal nerve in respect to the placement of where we need those functional position of those teeth and their centric occlusion. And on the right hand side, you'll see our 4-5 position implant positioned nicely away from our trigeminal nerve in respect to where we need the access channel to be in a 4-5 restorative component. And in the 4-6, you'll see the restorative component positioned here virtually and the implant placed respectively. So now we can ensure these two implants will be placed precisely where we need them, not only for osseointegration and longevity for the bone, but also for the restorative manufacture. A surgical protocol sheet is then also created, so there's no errors on the day of surgery. You'll see here the implant placement guide is then designed virtually, 3D printed, and positioned in the mouth for surgery. Here it is on the right hand side. You'll just see over here on the top right hand side what we call our access windows or visual windows, and this will ensure that the guide is placed accurately. If you see any gaps in this area here, you'll know you need to start the process again or check there's no debris to ensure the guide is seated correctly. If we have a look now, we can see in more detail, this is what we're talking about, and then post-op CBCT will then show us the position of those implants placed exactly in the same position. On the right, just here, you'll see our virtual implant placement, and our post-op CBCT X-ray or radiograph does show that our implant is positioned in exactly the same position. The 462, our virtual implant placement here, we can have a look at our post-op CBCT, and again, we see this consistency, productivity, and predictability that this system allows. I do have someone who is tapped in with their microphone. Could they please just mute out? I'm having some issues hearing through them. One of our team, please just double check that. On day of surgery, we can also provide a temporary crown on a titanium base, a custom tissue healing former, or a gingival training former, or a final abutment with temporary crown. So these are fantastic. So on the day of implant surgery placement, we can stitch on here and suture around that, or suture around the temporary, and get nice soft tissue emergence profile. Some people like to place the final abutment so the soft tissue will heal and we're not messing with that through removal and placement of final restoration. The temporary will then be positioned over the top, which again will be placed second stage with the final restoration. Here's how we position the emergence profile between the implant that we place virtually and the temporary final, or the gingival training crown or the temporary crown. It's like we would a tissue former. If you don't want to place the final restoration, you don't want any of the restoration in function during osseointegration, and you'll see how we do that connected to a titanium base as we would a final restoration. Here's the former in exact same shape as the cross-sectional position of the adjacent tooth, which ensures the soft tissue emergence profile matches perfectly to the natural tooth next door. Very powerful, very simple and easy ways to get nice soft tissue emergence profile. Here for anterior cases, you can see the positioning and how we emerge the soft tissue up in this area here to give us a final restoration, to give us a final temporary that goes in at day of surgery. As to with our tissue former, you can see the detail we can go to get that exactly the same shape as what the emergence profile would be of a natural root form. As to with our customized abutments, we can get those final ones done at day of surgery and the temporary over the top. Very powerful way to get the soft tissue results and aesthetics we need to get nice, even zenith heights around both those anterior teeth. Here's a different case we did with a iTero scan. The red is the iTero scan. The white is reflective of the CBCT scan. On the right-hand side, we can start looking at our implant placement, our emergence profile, soft tissues, our access channel for the screw restoration. We really can focus on getting direct driver and good torque without having to realign with coaxial or biaxial solutions. So planning this software allows us to plan better than we ever have before. The virtual guide is then designed. The virtual guide is then printed. On the right hand side, you'll see the print sitting on the model that was provided. It's then used to place the implant. Beautiful placement here by Dr. Keegan, and a final restoration here. Dr. Keegan is a lovely, lovely result. Okay, so surgery ready provisional designs, and you can see this is what I was talking about with the custom tissue former. We get a lovely result then, day of surgery, so you can suture around that. When we stitch the ginger around that, we can ensure the soft tissue is the issue, and we get nice results. Or we can provide a full contoured screw retained crown. We normally provide these on non-engaging abutments, so if there's any micro discrepancy in the rotation, the depth, angulation and rotation of that implant, you're not having to mess around with the temporary. So we do provide those on non-engaging abutments to save you time and headache. You can also get what we call a passive fit bridge, where if you do have a bridge, we can give you a passive fit solution for day of surgery. If you need to know more about that, let us know. Or we can get a Connect passive fit. A Connect passive fit is when we're doing a larger bridge. We can actually use the implant placement guide itself can be the temporary bridge. The pilot holes or anchor pins, the anchor pins are positioned here. And once you've finished placing the implants, you can cut these anchor pin sections off, and the implant placement guide itself becomes the temporary. Very fast, very efficient, very accurate. Here's the conversion matrix to do such. So the full arch workflow is a little bit different, and we have a dual scan protocol. So the CBCT scan is taken. We also ask for a second CBCT scan, which is of the denture by itself. So it's a dual scan protocol for full arch workflow, but pretty simple. We then import the information from the DICOM or the CBCT and the denture itself with the nipple stickers on it. You'll see the software allowing us to place those implants in the correct position and enable us to get the final results that looks fantastic. So here we can see the patient's denture, and we ask you to place these nipple stickers, and these are great. We no longer have to put these GP holes into patients' dentures. These are called shore mark places or nipple stickers. They just stuck on the palatal surface. We need a minimum of 3 on the palate or the lingual, and a minimum of 3, preferably 4 on the buccal or the labial. Then it's placed onto a block, and a cone beam or CT scan is taken of that denture by itself, sitting on a block. It's then placed back in the patient's mouth, and we take our second cone beam scan, and that information then is uploaded. Here's a good example of what that looks like in the where you sit it on a block. If I zoom in on that, you'll see this is what it looks like on the right hand side. So take a cone beam of your patient, and also take a cone beam of the denture on its own with these markers. Here you'll see the scan or what it looks like when you take your cone beam. I really love to lock these in to make sure the patient doesn't move during that cone beam. And on the bottom here you'll see the placement of these stickers on the lingual or the labial and buccal surfaces of that denture. Another good use for your rates boxes, if you're looking for some way to make use of them, and I think this is a courtesy photo by Dr. Wong. Thank you very much. It's a great use for the boxes. Would look much better in orange, I must admit, but thank you. Here's my recommendation for which markers to use. This is a CT mark, precision skin marking system. This is a Sure mark system. It was tipped into me, and I thank Mr. Brett Royal from Implant Concierge, who's a wealth of knowledge, and took me down this track many years ago and educated us on how to get the results we do. They're a fantastic company and a wealth of knowledge. These markers come in a number of sizes. The first one here is 1 mil, and they fly up to around 2.5 mil. Some people believe the 2.5 mil marker might help function a little bit better. I find them a little bit too big. Personally, I use a 1.2 marker. I think you can actually stick them on the denture, send the patient down for a CBCT, and they can hardly feel. So you can place them for the patient, and they can still use that denture in the meantime. After the cone beam's taken, the patient can pull them off, discard them accordingly. I think it's a fantastic system. If you need to know where to get these, please make contact with the customer support team. These are the ones we send out to all our referring surgeons. So just to recap on that, we do have a CBCT ×2, what we call our dual scan protocol. So ensure you take your cone beam with your patient, and ensure you take your cone beam of the denture itself on its own. On the right hand side here, you'll see those markers showing up. There, those nipple stickers coming up, those ball bearing markers. You can see it makes placement and planning a lot easier when you can see it and align, use that. You must ensure we have a successful merge, and we talked about the importance of that earlier. Initial treatment plan has to be right. Anchor pins for fully edentulous patients is important, and they are most of the time placed labially or buccally. Occasionally they need to be placed in the palate, but we try always to place them where they can be accessed, which would be closer to the anterior labral positioning. In this particular case, we've left the posterior occlusion on the denture, and we're going to take advantage of the centric relation with the mandibular to position that and hold it still while those anchor pins are placed. You'll see a little bit more in a moment. So here we're ready for the virtual implant placement. We have all the information lined up, and we're starting to plan where we want those to go. The implants are positioned. We also manufacture, we also print out our surgical protocol to ensure that all the information is given here on the day of surgery, so we know exactly where we're going on the day of surgery. On the right hand side, you'll see the virtual implant placement guide, and then we print that guide. Here you can see the posterior teeth set in there for centric positioning, the pilot sleeves just for pilot positioning, and the anchor pins around the outside. Very simple, very effective, too easy. So looking at tissue-borne guides with teeth and anchor pins. Here's the 3D printed guide design we just spoke about, and here is it positioned in the mouth. How do we position that and ensure it's positioned well for our anchor pins to be placed? And these, you can see the posterior teeth here in centric relation. Here's the interdigitating cusp with the lower left fall, and that centric position holds the guide in a perfect position to enable the surgeon to position the guide pins, or the anchor pins, should I say. And the anchor pins are placed, we can now open the patient's mouth, and we know we've got perfect stabilization with anchor pin. And that centric relation is the best way to do edentulous spacing or areas. Then the guide is then used for pilot osteotomies, and this one wasn't complete implant placement guide, it was just for a pilot osteotomy. So now the dentist has perfectly positioned holes to continue raising the flap and placing those implants. Fantastic system, very simple. We then go back after osseointegration and healing and take a look at our post-op CBCT versus our treatment plan. And you can see the position of this implant in correlation to the post-op positioning of the implant. The virtual implant positioning of the anterior implants with the CB, post-op CBCT, showing exactly implants being placed exactly where we want them to be placed. Predictable, reliable, any other way would be silly. Doing it traditionally by raising flaps, people still do, but I guess it's 90% mental and the other half is physical. Go digital, make it easy. So now let's look in detail at our post-op CBCT. The 1-3 virtual implant placement as opposed to the post-op CBCT implant placement, spot on. The 1-1 virtual implant placement, the post-op implant placement, and so on with the 2-1 and the 2-3. This cone beam post-op shows the positioning is identical to what we planned. Restoratively, every technician's dream. Clinically, every surgeon's dream. Simple, easy, effective, and reliable. So the surgical guide design, we will, through wherever we can, we try to make our implant placement guides tooth-borne. Better for stabilisation and much easier. So tooth-borne wherever possible. Mucosa-borne, obviously for complete edentulous or edentate patients, we need to go a mucosa-borne guide. Here's a mucosa guide, but centric related for positioning. And I always like to do that. That's that photo I showed you before to enable us to hold that guide in a perfect position while our anchor pins are placed. Mucosa-borne, which is only sitting on the mucosa. We have bone-borne, so times where we have to do an alveolectomy and reduce that bone, we can actually have bone-borne guides as well. And what we call bone reduction and connect. And I really like this system because space makes the case. So where we ask our surgeons to do alveolar reduction or bone reduction, we can actually provide our guides to do that. And this is an bone alveolectomy guide where it sits down here, the anchor pins are placed accordingly, and it enables you to do the bone reduction. So you can just sit simple grinding of that bone to match the guide. Once this is done, we use our Connect system to place the implant placement guide, snap straight into that initial bone reduction guide. So you don't have to remove one guide and place a new one. The Connect system snaps straight in. You'll see the pink is the implant placement guide, snapping into the grey, which is the bone reduction guide. So this Connect system allows us to do our alveolectomy and our implant placement guides in one go and not have to remove and replace. And I really think that's a fantastic system. Here's a two-dimensional version of it. The dark grey is the bone guide, the implant placement guide in light grey, all in one Connect. That's the printing of both clipped in together. You remove one, do your alveolectomy, clip it back in for the placement of the implant, and you get some beautiful, beautiful results. So the benefits of guided surgery: reduction in grafting requirements. Obviously, that's a very powerful tool, not having to do grafting, have nice pilot holes, nice positioning keys. There's a lot of benefits not having to raise that flap. You avoid anatomical complications. That's a no-brainer, especially technically. You can place implants more precisely. Here's a good example of a difficult implant that needs to place close to the root of two apical positions of these two adjacent roots. So this is a very simple way of placing implants perfectly first time. The flapless technique is another advantage, not having to raise the flap. If you do have plenty of vertical dimension, not raising the flap is much easier both clinically for you and the patient. The surgery becomes a lot less complex. It's much more simple to do digital surgery as opposed to raising the flap. And the most benefit is the improved prosthetic outcomes. And especially as an implant specialist dental technician, I can assure you that the outcomes that we deliver with digitally enhanced implant placement are far greater than we ever have before with traditionally placed implant techniques. And arguably some more improvements on the survival rates, a lot of because of those implant placements. We're not realigning access holes. We don't have any Lombarca techniques to deal with. It's very simple and effective. A confidence level can soar, and this is where it stings for most of our surgeons, gives them the confidence to proceed and grow and deliver outcomes first time. These guides aren't expensive, but virtual implant placement design and the guide itself, $295, and that's for unlimited sleeves, 1 to 10 sleeves, all inclusive. If it was going to be a completely edentulous case and you needed anchor pins, that would come at additional cost, but these simple guides, 295 Australian dollars for those international guests. Pretty cost effective, very simple and very predictable. So space makes the case. Vertical dimension is paramount, and when these implant placement guides and alveolectomy guides ensure we give the space we need to give the restorative material of choice what we need. So space makes the case. The soft tissue is the issue, and looking at these techniques, it does enable us to get the right emergence profile and then form that soft tissue in the right position we need to get the aesthetics, the function, and most predominantly the hygiene correct long term. And of course, bone sets the tone. If we get a nice platform to build from, there's no doubt we get a much nicer result. So if you get the right space, the right tissue, and the right tone, then the smile will last a while. From there, the restorative protocol is very simple. We have our Race Dental Laboratory, or Race Dental has our restorative lab card for full arch cases, and the grey one is the restoring clinician and tells them everything they need to do and when it needs to be done by. Comes to the lab, tells us what the lab needs to do, and we tick it off as we go. And this lab card travels with the case. We tick it off. This is what the restoring dentist has to do by when. The laboratory does the next issue, selects the fifth, does the setup, sends it back, and we can click off and ensure that everything is done when it needs to be done by. So on the final day of delivery, the case goes in, it's correct, and Mavis gets the bingo on time. The full arch implant case, an all-on-6 case, and please trust the digital intraoral scanning. Any of the leaders, the Trios, the Medit, any of those good systems allows any of their clinicians to do all-on-X cases digitally. We've done them, we do them a lot, we do them all day, every day. You can have faith that if a good scan has been taken, an accurate scan has been taken, we will get an accurate restorative result. There's no on-4 impression of what it looks like. Obviously, there's no maxillary mandibular relationship. That's fine. Take the upper scan with the scan flags and the opposing scan. Don't worry about the bite. It comes to the lab. We make a verification jig, which is a clear acrylic stent, and over the top of that, we locate our bite block. It's used as a verification stent. If it's not passive, it's cut and it will rescan as taken. If it is passive, we then soften the wax and treat this as we would standard bite block for a denture. Please mark the midline, but don't stop there. Use this bite block as a blank canvas. Nasal wings, come down and mark where the cuss tips of the canine should be. Ask the patient to smile. Mark that smile line. Then with digital smile design, we can then import the shapes of the teeth that we need and go through the Implant Placement Guide, go through digital smile design techniques to ensure we get a nice result. The try-in is then completed. You'll see the digital 3D printed model from a digital impression. We've then done a digital diagnostic, a diagnostic wax up, and this is another digital case. These are all digital cases going out as diagnostic try-ins. We spend a lot of time on our try-ins to make sure that the gingiva matches, because you want to get that colour right, because as we said before, the soft tissue is the issue. Full upper and lower can be done at the same time. Personally, I like to do the maxillary first, get a nice curve of Spey, Wilson, and Monson, and then interdigitate that according with the mandibular second stage. They can be done at the same stage if you are time constrained. Personally, I like to focus on my curves and then interdigitate. If it's a monolithic translucent zirconia bridge, we do the same technique with the try-in, the diagnostic try-ins. When it comes back, it's scanned in and becomes digitally manufactured from there. We scan it in, we reduce the buccal surface here, and for the gum porcelain. Here's the STL file of that full arch monolithic translucent zirconia implant bridge. It's then milled, the teeth are then stained. It's completed. This is monolithic translucent zirconia teeth here. So let's now look at a live digital case. We've got a couple of minutes now and I'll finish on a live case we did for a patient. Here's the implant placement guide on the left, and I've pre-made my lower temporary denture with holes placed exactly where I want them to go. And then basically I sit this implant placement guide over a model and I just mark where the holes are, and I put the denture over the model and drill holes where those marks are. It's pretty simple stuff for a temporary. This patient had lower anterior teeth. They were extracted on day of surgery. Teeth were extracted, and I thank Dr. Fred Calavassi for working with me on this case. His work is fantastic and is a master at what he does. So thanks for doing this with me, Fred. It's much appreciated. Teeth are extracted, the implant placement guide positioned, and the anchor pins placed for stabilising that implant placement guide. The implants then drilled and positioned. We then removed the guide here and had a look at how parallel it was, and this is a final example about how perfect this result's good. So we know they're on the right track. The implant placement guide was repositioned and the implants were then completed. The final implants were then placed. We removed the pins. Then we raised this flap, did some bone contouring where we used the tungsten here to remove this bone, so it gave us a little bit more space and a nice level platform or playing field for this restoration. The healing abutments are then positioned and sutured around. Once we have a suture of the final restoration in place, the final healing abutments in place, we can then take those off, put our temporary titanium cylinders in place, open up any holes to ensure the prefabricated temporary, or you can use the patient's existing lower denture. A rubber dam is placed over the top so any acrylic is not getting into the fixture connection. The denture is then tacked in place. Now I just finished this. The darker pink here is the pre-existing temporary. The lighter orange colour here is the fast set that we tacked in the mouth. You can see here I just did a quick light cured polish around the fitting surface here. It's then screwed in position. Any occlusal adjustments are made. We had a couple of posterior contacts in the first 4th quadrants that we reduced, and in under 2.5 hours the patient sits up, can go home and eat light food. 2.5 hours of surgery for a full arch, temporized, all on 6 restoration. Very powerful, very simple, very predictable. So let's take a look now. The upper I did for this patient 7 years ago. I think that's a full arch milled titanium hybrid denture on the maxilla on 6 implants. 7 years post-op, and here we have the final restoration in place, which is a milled titanium bar implant hybrid denture on 6 implants on the lower. This was post 4 years. If you look on this disto-incisal corner of the 1-1 here, you see the light and the translucency and opalescence showing through of this premium denture tooth, where I elected not to realign the access hole, but I thinned this end, but I think it looks quite nice thinning it out. So those imperfections can be quite nice. And here's the patient, 7 years from the upper, 4 years post-op of the lower, and it's super important. I've got this one right. This is my mother-in-law, lovely lady, had to get that right. One of the ones you definitely don't need to make any errors on, but showing the importance of this case and the importance of implant placement guides, how predictable the outcomes can be. Beautiful result, beautiful lady. So here we have a picture of Abraham Lincoln, who says, "Give me 6 hours to chop down a tree and I'll spend the first 4 sharpening the axe." And I really think it displays the importance of planning and planning a result. The best way to predict the future is to create it. My name is Matt Race. I work at Race Dental. The future is now. Thank you very much for joining us today. As usual, I'm going to throw over to questions. Whitney, are you there, and do we have any questions?
Hi, Matt. Yes, we do have one question. It's from Dr. Alvin Wong. He asked, what would be the most significant error affecting the accuracy of the guided template as a result of the operator, and how would I avoid this?
Great question. Generally, if we get everything right, you won't have any issues. The biggest issue clinically would be that the guide wasn't seated. And we spoke about those access windows, or those visual windows that we cut predominantly over cuss tips or marginal ridges, to enable the clinician to check that that guide has been seated correctly. And the more windows we put in there, the easier that is to check. So just double check that there's a snug fit of the guide around the tooth in those windows. We also leave underneath the area a lot of open areas, and that's for irrigation. So you can get nice, cool water in there to cool down while you're drilling. So yeah, the most predominant error would be not setting that guide correctly.
Okay, and that was the only question that had come through, but if you guys do have questions, you can email them through to customersupport@racedental.com.au and we can always get back to you.
Sure, we did have some questions also coming through here from Dr. Dean has asked about the everything we make here. The guides are printed, 100% printed in Australia. The rings are placed here as well, so they're included as part of the guide. Any material that you use to print a guide needs TGA approval, so make sure you do your research on that. But Whitney, is there anything else you need to add?
No, that was all. Thank you, Matt.
Look, I really appreciate everyone's time. Don't forget, if there's anything more you need to know, make contact with customer support. Alternatively, email me at matt@racedental.com.au. I'm open to help anyone where I can. But again, thank you for touching base. Please feel free to utilise the lab, 100% Australian made at head office, for all our race customers in Australia. So please feel free to make contact anytime. And I do thank you for joining us today. Look forward to seeing you again shortly.